Good morning, everyone. My name's Karan, and my presentation today will be on spheres therapy in paediatric patients with primary hepatic malignancy, and specifically speaking about two cases which occurred at a quaternary level paediatric centre in Australia. So to start with, and I hope this provides some context to my presentation, and also allows everyone else to get involved as well, I'd just like to explain who I am and why I'm here today. So as I mentioned before, my name's Karan. I am outside of work. I love good coffee. I love wine. I love slow mornings, and I love spending time outdoors. I think that's so important to think about that stuff before we delve into the work and career aspects of our lives. From a work perspective, I'm an RACP advanced trainee. I completed basic training in paediatrics and child health, and I'm currently a first-year advanced trainee in dual-enrolled in general paediatrics and nuclear medicine. Two very different but also similar specialties. Why paediatrics? Because I love working with children. I think they bounce back quickly. I find their physiology fascinating. And why nuclear medicine? Well, I find it intellectually stimulating. I love the diagnostic side of it, and I think it's got a lot of potential for change moving forward. So why have I chosen to talk about spheres therapy? And for those of you who this is new to, as it was to me a couple of months ago, SIR is selective internal radiation. I wouldn't be very much of a paediatric trainee if I didn't try to force some Simpsons references into my presentation, so here we go. So I'll be speaking a little bit about all of these aspects of spheres therapy. Firstly, what is it? It's a therapeutic procedure, and it's routinely provided or offered to children and adults that have chemorefractory or unresectable hepatic malignancies. Now, the way it's conducted is essentially we have these tiny, tiny little spheres that are thinner than a strand of hair, and the spheres themselves are impregnated with yttrium-90, a radioisotope of yttrium, which is a chemical element found often in, it is quite rare and is often used in alloys or to strengthen the properties of aluminium. Now these spheres, the way that they get to the tumour itself, so the spheres, are impregnated with yttrium-90, and yttrium-90 emits beta radiation, which kills tumours. So the problem we've got is we've got this great therapy, we need to deliver it to the liver tumour. To deliver it to the liver tumour, we have some fancy, very smart people called interventional radiologists that access the hepatic artery through the femoral artery. And the reason for the hepatic artery is that's often the blood supply for a lot of hepatic tumours. Now, in the past, it's been a therapy that's more routinely offered to adults, but more recently, the world of paediatrics has joined as well, and we're becoming more comfortable with administering it to children. There are many pros and cons, and I'll speak about those towards the end of my presentation. So the other part of my presentation is paediatrics, and that's probably slightly unique to my background in this presentation. So paediatrics, as we know, encompasses the care of children and adolescents that range from neonates all the way up till their 18th birthday. And so speaking to procedures, we know that paediatric patients have different anatomy, different physiology, and different social circumstances that surround them that sometimes make therapies a little bit more difficult to administer. So today we'll be talking about two specific patients. Patient number 1, who was presented as a neonate to a quaternary level paediatric centre in Australia, and patient 2, a young girl at the age of 6 who presented. I'll speak about their presenting complaints. As I mentioned, they both presented to the Children's Hospital at Westmead over the last 10 years. So this is probably the crux of my presentation in terms of this slide. And I'm not going to repeat everything because I know that everyone can read. But I've briefly outlined the two different patients, their ages of presentation, and their primary malignancies. Important to note that patient 1 had a diagnosis of hepatic angiosarcoma, after many, many years of diagnostic procedures. And patient 2 had a diagnosis of hepatocellular carcinoma with pulmonary metastases. Both were deemed inoperable and both were refractory to chemotherapy, and therefore a palliative approach was adopted. As part of the palliative approach, to assist with increased quality of life, reduced pain burden, and prolonged quantity of life, SIRS-FIRS therapy was initiated in conjunction with the nuclear medicine team, oncology team, and interventional radiology teams. Importantly, to prevent side effects and to understand the degree of lung shunting, hepatic angiography with technetium-99m and macroaggregated albumin was implemented or undertaken before the procedure. Both patients had scans which demonstrated no non-targeted MAA uptake, and both had degrees of lung shunting of 6% and 16% respectively. Therapy was initiated in both patients, and you can see the doses there. In terms of post-procedure imaging, patient 1 had PET-CT scan done approximately 1 month after the procedure, which showed a stability in the size of the lesions. We're still awaiting patient 2's post-therapy scan. From a post-operative course, patient 1 did have improved pain control and pain analgesic requirements, therefore leading to an increased quality of life during that palliative phase. She passed away 4 months later. We're keen to observe the progress of patient 2 over the coming month. Now, a little bit about discussion about this therapy specific to paediatrics. So what did we already know? We know that this is a safe and technically feasible procedure in adults. And we also know from small case studies which have been published in the United States that this has been implemented in children as well. What have we learnt from the 2 procedures that we've undertaken at the Children's Hospital at Westmead? Well, we've once again confirmed that both are safe, technically feasible, and in both instances, families were keen to go ahead with the procedure. The good bits, as we've mentioned before, are that the procedure went ahead without any major complications, and it's opened up avenues for such procedures to happen in the future. It also provides education to different parts of the multidisciplinary team that this is a therapeutic option available in children with chemorefractory and inoperable liver tumours. The not so good bits, we didn't really encounter any during our 2 case series today, but in general, there is the theoretical risk of pulmonary, or rather pneumonitis, which can occur when the degree of lung shunting is very large, or damage to the gastric, duodenum, or different parts of the intestines. And to combat or counteract this, hepatic angiography is done prior to the procedure to understand where the SIRS-FIRS are being lodged. So moving forward, it's very important for us to understand that SIRS-FIRS therapy is a safe and technically feasible procedure. We, of course, need to think of a few different things moving forward. First is more research, more case studies and case series need to be published so that this is thrust into the mainstream therapeutics. Number 2, we need to continue to provide education to our primary healthcare practitioners, or rather the specialty teams where these children present. Specific to this instance, that would be the oncology teams and the gastroenterology teams, but also the general paediatric teams. So important to break it down into simple, easy to understand concepts so that people are aware of this therapy. The take-home points for my presentation include that SIRS-FIRS therapy in paediatric patients with inoperable and chemorefractory hepatic tumours is safe, it's technically feasible, and should be considered in these subset of children. Thank you very much.